Right, everyone, we're now live on air, and I'd like to welcome everyone to the 6th Google Hangout hosted by MS Translate and the 5th in collaboration with the Melbourne Brain Centre. Tonight we have the privilege of being joined by Dr. Anneke van der Walt, who's been a member of all of our previous Hangouts but is the star of the show tonight. And Anneke will be talking about her work involved in research looking into tremors in people with MS. So without any further ado, I'd like to hand over to Anneke to introduce herself, and then we'll throw over to everyone for questions. Anneke?
So my name is Anneke van der Walt. I'm a neurologist at the Royal Melbourne Hospital, and I subspecialise in the care of people with multiple sclerosis. I'm also a postdoctoral research fellow at the Melbourne Brain Centre, which is part of the University of Melbourne. And most of my doctoral studies and postdoc has been to do with, studies relating to people with multiple sclerosis.
We have the privilege of being joined by Dr. Anneke van der Walt, who's been a member of all of our previous Hangouts, but is the star of the show tonight. So does someone her work research looking into tremors in people with MS. So without any further ado, I'd like to hand over to Anneke to introduce herself, and then we'll throw over to everyone questions. Anneke?
So my name is Anneke van der Walt. I'm a neurologist at the Melbourne Hospital.
Yeah, so someone's got this open in the background.
The care of people with multiple sclerosis. I'm also a postdoctoral research fellow at the Melbourne Centre.
Yeah, can you just check if they've got this open somewhere else?
Most of my doctoral studies and postdoc has been to do with, studies related to sclerosis.
Oh, I think it's
yeah. Okay.
Don't get rid of it. Sorry about that. I had it open.
Sorry for those technical difficulties. All right, Anneke, we'll throw back to you.
You seem the guilty party.
So what I was saying, most of my research has been looking at optic neuritis, and then also at the treatment of tremor in multiple sclerosis, which is what we're going to talk about tonight. So this particular study was quite novel in that it was the first study looking at the treatment of tremor in people with multiple sclerosis using botulinum toxin injections, or Botox. And we did this in a double-blind, randomized control study. So we recruited 23 patients with MS. And when people had tremor or shaking in both arms, we used both arms. So we ended up with 33 limbs that we tested. And the people in the study were randomized to receive either Botox or saline injections, like salt water injections. And then after 3 months, they swapped over. So if they had Botox first, they would have saline second, or the other way around. And the reason we did this was that each person could serve as their own control. So this makes it, a very carefully controlled study. Not a lot of other variables that could influence the results. So we looked at each person's tremor individually and then designed the range of injections that everybody had. So most people had about 5 or 6 injections in particular muscle groups, and the results of the study was very positive. So overall, we found that the tremor severity reduced by 30% on average, with some people getting 100% response and had a complete ablation of the tremor. And the other thing that was quite encouraging is that we could show that people's writing ability and their ability to do tasks such as drinking from a full cup of water or pouring water from one cup to another improved again by about 30 to 40%. So that's quite a substantial, functional improvement. So we were very pleased with these results because they did show what we thought was happening in some of people we used it off-label in our clinic on, and we're now looking at this, starting a bigger study, because clearly this was quite a small study, and we're hoping to get people enrolled in a bigger study, hopefully by the latest next year, to get this licensed onto PBS so that it could be a freely available treatment.
Okay, thanks, Anneke. All right, we'll hand over for questions. Does anyone want to jump in with a question for Anneke on any of this?
Anneke, I was just going to ask exactly what is it? Are the muscles in the arms actually targeted? What exactly is being targeted by the Botox injections?
So Botox or botulinum toxin is actually a toxin that actually interferes with a transmitter that transmits nerve signals into muscle. So it interferes with this transmitter called acetylcholine, and it actually completely disrupts that signal. And the cell actually has to completely regenerate these receptors. So that's why the effect of it lasts about for about 3 to 4 months at least. So what we did is we used this toxin and looked at the muscles that were generating someone's specific tremor. So for instance, if someone was shaking like this, then we would look at some of the forearm muscles on that side and on this side. We also found that a lot of people were doing this, so what we call pronation and supination, so from side to side or this way. So again, we kind of look specifically at those muscles. So, we know where those muscles are from basic anatomy, but we also use a little device called a neurostimulator, which we, you attach the syringe to that, and you can actually target the muscle and make the muscle twitch. So we knew exactly, that we were in the correct spot each time.
Lovely.
So,
very interesting.
Yeah, so I think that's part of the reason the study was successful, because it has been tried in other types of tremor. So in people with essential tremor, which is a type of tremor that you get when you're older than 60, and it also has been tried in Parkinson's tremor, but it wasn't that successful because they generally had a prescription. So they made everybody have exactly the same doses and exactly the same muscles, whereas we did very targeted injections. So we individualized it to each person, which makes it much more clinically relevant, because that's what you would do in clinic. You would, give everybody is different. So, and I think that's why these results were so significant.
Thank you, Anneke. That's excellent. Very, very good. Very interesting.
Andrew, do you have throw over to you?
Thank you, Anneke. Yeah, as Anneke's aware, I've actually been the beneficiary of the study and ongoing treatment, and I will tell everybody on the line that it's made a heck of a difference for me personally, and I know of other people that have had it as well, and it's made a substantial difference. I guess the question I have, Anneke, at one stage, when I was in for treatment, I was having a discussion with one of the team members that provides the ongoing treatment, and there was some suggestion that when the tremor reduces, the body actually, or the brain, appears to be learning from the changed behaviour in my case, in my left arm and hand, and that you may actually get longer periods of effectiveness of the treatment, and indeed maybe that the brain is kind of retraining itself to adapt back to the proper functionality. And I just wondered what you might be able to tell us about that.
Yeah, I think that's a really interesting question, Andrew, because it's quite, it's still not very clear how this exactly works, because we know that the actual tremor in people with MS is generated in the brain. So how does injecting a muscle with some sort of drug make the brain change the way that it drives this tremor? So it's quite an interesting question. So what we think happens is that the way that tremor is generated in the brain is because of a disconnection between the cerebellum, which is the back part of the brain, which controls movement and coordination of movement, and also the basal ganglia and the thalamus, which is these deep structures inside the brain, which basically receives the input and then sends it up to the cortex, where all the thinking and decision making happens. So in that dysregulation, because of the MS lesions and the inflammation, there's an abnormal circuit that starts. So it just starts rolling, and the movement gets disinhibited, and that's why you get these oscillatory shaking movements or tremor movements. So what we think happens is if we inject the muscle and interrupts the signal that the brain receives from that muscle, by making that muscle just a slightly bit weak, it might actually break that circle, because the brain also obviously gets a lot of feedback from joints and muscle as to where things are in space. So that sort of peripheral mechanism gets interrupted, and that interrupts the circuit in the brain. So we don't know if that actually leads to a permanent disruption. It certainly seems that some of the people we treated in the study had up to 12 months of a response, and didn't need to be re-injected. But then some people needed it much shorter. But invariably, everyone did need to be retreated. So it doesn't look like it leads to a permanent sort of neuroplastic response, which permanently changes the way that the brain works. But it would be very interesting in future studies to follow people up for longer, to work out how long does it last and does it differ between different people. Sorry.
Thanks, Andrew. I guess just following on from that before I chuck it over to another question, is there any limitation in terms of the amount of treatments that people can get with this, Anneke? Is there any sort of, do you have an idea as to how often people can get treated for it? If there's a point when you'd have to stop giving the injections?
Well, there certainly is a maximum dose that people can receive. So we usually wouldn't give more than 300 units in one go. So the drug comes in little vials, and those vials are 100 units in a vial. And then the minimum amount of time between doses is 3 months. So that's how long it takes for those nerves to re-sprout all their receptors. But we really found that people usually only need a treatment every 6 months, and it looks like there's a lot more of a sustained response, which goes beyond just the biological function and the effect of the drug, which is very interesting.
Yeah. Okay, any other questions? Tony and Brad, do you guys have a question that you'd like to ask?
Yeah, Anneke, I would just like to ask, what similarities are there between the tremor research that you were doing and clonus? I ask that specifically because that is something that I have experienced in my MS travels. And at rehab, they were getting all excited about injecting me with Botox, but thankfully it sort of has just decided to calm down by itself. But what is the relationship between the two areas of study that you see?
Well, Tony, I mean, you touch on a very good point in that Botox certainly has been used for clonus or spasticity or stiffness in the limbs of people with MS for quite a long time. So it basically, what causes the stiffness in people with MS is particularly disruption of spinal cord pathways and also in the brain itself, where there again is a disinhibition where your brain doesn't suppress all the signals that it's getting, and that causes the legs and the limbs to go stiff. And when it gets to a certain point, then you can get clonus. So for those who don't know, clonus is sort of a spontaneous, sustained movement of particularly the ankles and around the knees. It can happen where the leg can jump up and down. And that can be, pretty annoying and also quite painful. So sometimes Botox in specific areas in big muscle groups in the legs can help for that. And it's pretty much the same mechanism as it would be with the tremor, and that it just helps to disrupt this abnormal pathway and signal that's coming from the brain. But I guess, it all has its own limitations, and, spasticity, you generally can't treat it just with Botox. Like, it generally requires quite a coordinated effort with injecting the Botox and actually involving a physiotherapist. So you need a lot of stretching to get the most benefit from it. And sometimes, very often the Botox is not that effective because of the size of the actual muscles that you need to inject in the legs. So the doses that would be needed would not be safe. So, but for very small and targeted muscle groups, it can be very helpful. I hope that answers your question.
I guess that, just to again follow on from that question, there was a comment posted by Helen Webb, who's joined us for Hangout in the past, talking about how Botox is currently covered by the PBS for the treatment of chronic migraines and urinary incontinence, which are obviously both symptoms that are also quite common in people with MS. But I guess in terms of the use of it, it's difficult to use it as a one treatment for all these different symptoms, isn't it, because of how targeted it needs to be? Do you have a feeling as to how it could be used to treat multiple symptoms?
Well, there's certainly a lot of areas in MS where it can be very effective, and I think, we've already talked about spasticity. It also can be affected in people with MS with a certain type of urinary problem, so where the bladder is constantly contracting, and injecting the bladder muscle can actually relax it and give you up to 12 months of relief. So yes, I think, that's part of the problem. Is what we try to do with the tremor studies is to actually provide the government and the PBS with enough evidence to show that this is effective. So generally they would like more than one study before they would take this into account. And that's what's happened with the chronic migraine, for instance. There's been quite a number of drug companies sponsored sort of studies where they showed this conclusively, that it's effective in certain types of migraine. So we're hoping to translate this study into that sort of government policy, enough evidence to change government policy, and it's just unfortunately quite a slow process. But there are ways around it. I mean, obviously, Botox can be really expensive. So for the average person, if you're going to try and pay for this in private, it'll probably cost you between $500 and $1,000. So it's quite expensive. But there are clinics, in the public hospital, like at Royal Melbourne, for instance, where we do have a way of funding this for people with MS, so it doesn't cost anything. But we do need to move this process with policy changing forward, because generally hospitals run out of money and look at ways that they can cut things. So we don't want to land up in a situation where we can't fund it anymore for our patients.
Okay, question?
If I can add another question.
Yeah, of course.
Anneke, I think one of the things I've read with Botox, one of the long-term issues that's seen, I think came out of the cosmetic application of it, was that over a long period of time, I believe it can start to affect muscle strength and cause a reduction in muscle strength. And I was just wondering, had you seen that happen at all, and or had you implemented a regime of strength conditioning for those same like forearm muscle groups at the same time as doing the Botox?
Brad, we haven't seen that to this point, and I think part of the reason is that the muscles that we're injecting are so abnormally overactive. So we're just reducing that, abnormal increase in activity, which is different from when you do a cosmetic injection, for instance, into a normal muscle. So we certainly haven't noticed any weakness developing long term, or any shrinking of the muscle at this point. And we have a few people now that's been receiving the treatments for a number of years, and there hasn't been any issues. However, I do have to say that acutely, so just after the injection, within the first couple of weeks, because of the way the drug works, we can make the muscle weak. So, and usually that's a transient thing, so lasting for 2 to 3 weeks. And it's generally mild to moderate, so people can still use their limb that we injected, and it does recover again. But obviously, it can be quite annoying. And I know I remember we injected one lady who was actually using her upper limbs to transfer in and out of a wheelchair, and that little bit of weakness that we caused in that arm actually put her back quite a bit. So for a few weeks she became quite dependent because of that, even though she could still use her arm. So there is that potential side effect, but luckily it appears to be mild and transient, but nothing long term, fortunately.
Excellent.
Questions from anyone else? Andrew, Adolfo?
Yeah.
I've got a question. Okay.
No, go on. That's okay. I already had that. Go on.
Sorry, I might just sorry, Elizabeth asked the question.
Yep, sorry. I have quite strong, very often myoclonic jerks, and from what you were saying about clonus, I'm assuming that, because I suffer from them with my shoulders, my neck and my head, and I'm assuming that Botox isn't an option because of the area that it's in.
Yeah, that's right, Elizabeth. So the myoclonic jerks, so myoclonus are these very brief, they like little twitches. They're actually very hard to imitate because they're so quick, and yes, they can affect all sorts of muscle groups, and you get different types of those of myoclonus. So the one form is epileptic myoclonus, where it actually gets made, generated in the brain itself, and it's a type of epileptic seizure that would respond to anti-epileptic medications. So, and the other form that we see in people with MS is a spinal myoclonus. So that's usually from an area in the spinal cord that's been affected by inflammation. And those specific muscles that's in that nerve distribution of that area will then start twitching like that. Now, those sort of things they're not really amenable to treatment with Botox, unfortunately, but they often respond quite well to anti-epileptic drugs. So that's probably what I would try if it's really annoying. But if you it might be worth just checking and making sure that you've had an EEG and making sure where those little jerks are coming from too.
Yep, thank you.
Adolfo, did you have a question that you wanted to ask?
Yeah, Anneke, I just in relation to, I was interested in the handwriting aspect, improvement in handwriting. Seems to me that that would be a terrific diagnostic marker for early onset, or at least to diagnose people early, if you can actually confirm diagnostically that, say, a handwriting pattern or tremor that's been identified through the handwriting analysis relates back to damages to the upper cervical or the cerebellar pathways which control the muscles for hand control.
Yes, like handwriting is just fascinating. But I think, we found that most of the people that we studied only developed these changes on average 10 years after diagnosis with MS. So it certainly doesn't appear to be there early. And but what we do know with regards to handwriting, though, is that there is a type of dystonia. So dystonia is an abnormal contraction of muscles, so opposing muscle groups that don't work smoothly and cause abnormal postures of hands, and when you do something, it pulls your muscles in a funny direction, I guess. And a type of dystonia called writer's cramp is more common in people with MS than in the general population, and that can certainly appear at any point. But it's never been, clear if that's just, like there's only been one little study really, and it's not clear if it's just a coincidence or if it's actually related to the MS itself. But yeah, still a lot of work to be done, but I don't think it'll work very well as an early marker of, disease.
I think the problem, the essential problem with multiple sclerosis is that we're all pooling multiple sclerosis in one big bucket, but most likely there are actually subsets of different causes or different origins which create a type of syndrome, and that is actually what you're seeing as a diagnosis. But the actual cause of each, so there is such a heterogeneous range of symptoms. It's likely that for any treatment or any diagnosis or any analysis is going to be only catching a few people in each bucket. This is the problem. We just can't say that multiple sclerosis has one origin or exactly has one basis. It could be, and as the genetics indicate, there is a huge range of genes involved, and there's a huge range of environmental factors that could be at play. So, diagnosis is the hardest part.
Right. Yeah, you're right, Adolfo. I think there's a huge variety in the clinical spectrum and also pathological spectrum of people with MS. And you're right. It could be possible that there are people who have particularly handwriting abnormalities, and we just haven't studied it enough. So.
Or tremors, or optic, or say tremors in the optic nerve, or in muscles controlling the eyes or the face, or all sorts of weird and wonderful things. That's right.
Yeah, that's true.
We tend to talk about this on most Hangouts, don't we? That the different presentations of MS is what makes it so difficult as a condition to research, because you don't know really what you're looking into case to case. Andrew, did you have another question that you wanted to ask?
Yeah, I did. Thanks, Brett. Anneke, I'm wondering whether there's been any consideration with the additional trials that you hope to achieve, whether there's been any consideration about people that are undertaking this type of treatment, whether there's any benefit to, at the same time, undergoing, say, some physiotherapy or some other rehabilitation type treatment, whether with the greater control over the tremor by virtue of the Botox, whether then if people go away and do some rehab, they may actually improve their functionality, not purely in relation to the tremor, but in terms of the use of the hands and arms and so on.
Yeah, I think that's a really that's a good point, Andrew. I guess what you're saying is, so instead of just having people being compared against placebo or a saline injection, having both groups have some sort of active treatment like physiotherapy, there's certainly a consideration. And I think you might, if you look at the video that's going to be posted tomorrow on MS Translate, there's actually some new robotics technology that seems to help retrain upper limb function, and it might be beneficial in people with tremor. So certainly something that we have to consider. I guess in terms of the history of it, though, if you look at the published literature, there has been lots of different devices tried for people for tremor reduction, and also physiotherapy maneuvers. The ones that seem to benefit people the most is actually a weighting gadget that you can attach to the arm. So weighting the arm down can actually reduce the tremor. But often that can be quite uncomfortable, so not only for short durations of benefit. The other thing that really helps for reducing tremor in people with MS is actually ice water. So dunking the arm or the limb in into a bucket of really cold water for as long as you can tolerate. And that seems to, in the study that's been published in neurology actually, it showed that it reduces the tremor severity for about 30 minutes. So, which is interesting, all the temperature things in MS, but it just seems to slow the nerve conduction down enough to give people some relief. So, it's sort of been advised for people when they're going to sign their, wedding registry or, something like that. They can have their ice bucket there ready. But yeah, unfortunately, all these other things have been very short-lived, the benefit, and can be a bit impractical. And then I guess there has been, studies on other drugs, using other types of drugs for people with MS tremor. But the study quality, unfortunately, was all quite poor. So it was often unblinded, so everyone knew who was getting what. So that doesn't really help. Or there was no comparison group. So again, you don't know really what's going on. But there are, from my clinical experience, there's a couple of drugs here and there that seems to help for people, especially on the milder tremor. Particularly some of the beta blockers seems to suppress that a little bit. So, I guess coming back to your point, it's not a bad idea to think about some sort of active comparator. But there is no gold standard treatment, though, so it's a bit difficult.
Yeah, just to follow on from the comments on the rehab side of things, and as Anneke mentioned, we're going to have a video up tomorrow, following on from the video we had with Fari Khan yesterday, talking about the facilities they have down there, highlighting the hand hub, a really exciting new facility that they have there. But also on the back of that, just to pass on a question we had on the Facebook page, which is more to do with the rehab side of things, but I'll see if you can comment on it, Anneke, and we might throw it over to Fari at a later date as well. But this comes from Peter Sullivan, and he wanted to ask about developments in the role of telemedicine in enabling access to multidisciplined MS rehabilitation. And he says the issue was raised in December 2012 by Dr. Michael Barnett when establishing an MS-related telemedicine facility in Dubbo. Dr. Barnett said it's logistically impossible for many patients with MS to travel to our clinic on a regular basis, potentially compromising their medical care. We felt it was important to establish some way of providing timely and accessible care to patients with MS in rural areas. And so Peter was interested in finding out whether researchers are factoring this impossibility factor into their work, and if so, how, and comments 50% of the MS populations in New South Wales and Queensland live in non-metropolitan areas. Can you comment on that at all?
Look, I think it's it's a very big problem, and I think there are active moves in trying to address the situation. So I guess there's a couple of aspects to the telemedicine thing. The first thing is actually the active treatment, or seeing your neurologist, for instance. And we are actually looking at the Royal Melbourne setting up specific telemedicine appointments to help our patients who live in the country, so that they don't have to drive in. And that would work for sort of a briefer visit, where it's more about medication adjustment and symptom treatment, rather than being reliant on that examination, which is so critical to what we do. The second part of it is the rehabilitation bit. So I think that is what Professor Fari Khan is trying to set up with her interactivity hub. at the Royal Park campus at Royal Melbourne Hospital. So they basically are trying to obtain funding at the moment where they can provide, for instance, physiotherapy through a telemedicine portal where one physiotherapist can have almost like a format like this, for instance, where, you know, everyone can be in this group together doing the same exercises or, you know, going through the same program, which would actually, you know, help a lot of people who just do not have access to a specialized physiotherapist. So I think that's good. The third thing, I guess, that, you know, in lieu of that sort of you know, like real-time interaction, is the use of webinars. So a lot of the MS societies actually set up courses that you can do. So fatigue courses, for instance, or a course on sexual health, or sorry, that you say do one seminar a week for 5 weeks, and, you know, you can provide sort of feedback. It's not, you know, as real as being there in the room, but it can be the only option. And I know, for instance, we're looking at the moment at setting up a webinar sort of thing on sexual health with MS Australia, because one of those things is that, you know, people might actually prefer to look at something like that online rather than, you know, being in a room with other people. And the same with bladder and bowel function sort of information seminars that you can look at on the web. A lot of people prefer to look at that in the privacy of their own home. So look, it's slow, but I think, you know, it is getting there, and certainly clinicians and rehab people are very aware of this issue, and that, you know, we need to address it.
All right, so I might take this opportunity just to ask for sort of last questions from anyone. We'll start to wrap it up a little bit, but if everyone wants one last question, if anyone's got any. Anyone? No last questions?
Can I ask a question?
You can.
I wanted to ask Andrew a question. So, Andrew, what do you think the biggest benefit was that you got from participating in the Botox study?
That's a terrific question, Anneke. I think it really gave me, at the time that I started in the study, I was still working full-time, and I've now finished working. So we're talking over a 2-year period. And the type of work I did, I work in the human resource field, and there was a real need to, you know, write and be able to do things that allowed me to do my job effectively. And the tremor was an aspect that really got in the way and made life more difficult. So my company was actually extremely supportive of me over a very long period of time with my diagnosis with MS. But also practically it presents them with a problem when they want you to do particular work, and because of a symptom, be it the tremor or something else, you're really struggling to be able to do something, then they start to say, well, maybe this isn't sustainable. And so the benefit from the trial for me and from the ongoing treatment has really meant that I could continue to work for a longer period of time, and to do that in a really effective way. So, you know, that was something for me personally that was very important. And I guess just simple things around the home. My wife Julie would complain or would say to me, "Don't put the dishes in the dishwasher, because there's a fair risk you're going to smash all the plates." And so, again, having the tremor under control means that I'm back on loading the dishwasher duties. So both sides. So it's been fantastic.
So we've improved her quality of life too then.
Absolutely. Which in turn means my quality of life improves, you see.
Okay, well, does anyone, one last question for anyone? No?
No, just
I
thank
was
you
going to ask
very much.
Anneke. Yeah, I'll go on. Sorry, go on.
Oh, I was
After
just
you.
going to say thank you very much for Anneke to give up her time and be with us tonight.
Oh, it's a big pleasure. I've really enjoyed these sessions. It's really good to feel like you connecting with the MS community because I think we tend to have quite a narrow view sometimes. So it's been a real privilege to get to know you all.
Anneke, before you go, I was just going to ask one last question in regard to the program that may be getting off the ground there at the Royal Melbourne Hospital. When do you think it will happen? Any ideas? Or?
Well, look, we've been in negotiations for quite some time, and we basically are just looking to get the last few dots and crosses to get the software package that we need. So it's not far off. I would reckon in the next month or two we'll be able to do that, and people would be able to book a telehealth appointment, which we would just incorporate into our normal clinic hours, really. But we have patients coming from all over Victoria, so I think it's going to be very helpful for them.
All right, so it's just a matter of ringing up the MS clinic and seeing if it's ready or not. Yeah, gotcha.
Yeah.
Okay.
Yeah.
Anneke, is that for Victorian residents only, or can New South Wales people do that as well?
Oh, Elizabeth, I think at this stage it's probably going to be Victorian-based and probably going to be very Royal Melbourne Hospital-based. Unfortunately, there's no sort of statewide coordination of these services. So everyone kind of tries and develop their own thing. But we're hoping if we can show that it's successful, then other hospitals could adopt the same model. So hopefully, coming to your area soon.
Yep, excellent.
Okay, actually, one last question. Sorry, Adolfo. One last question about the Botox treatment. You said that you were looking at making a larger trial for that. Is that something that there'll be recruitment for? And if people are interested, can they find out more information?
Yeah, so we're just waiting again to shore up some funding. So we're waiting for the NHMRC grant process to finish, and then we're hoping but I think regardless we'll find a way to do it, and probably we'll be looking at starting recruitment early in 2015. And I think what we'll do is we'll make sure to advertise it on MS Australia website and so forth, so that people are aware and can contact us to come and get the treatment.
Okay, fantastic. All right, well, then I'd just sort of like to finish up by thanking Anneke for being involved not only in this Hangout, but in all of the previous Hangouts. This is the final in our current series of feature weeks with the Melbourne Brain Centre, but we're very much hoping that we will be extending this partnership well into the future. But for those of you that sort of haven't seen everything that's been going on behind the scenes, Anneke has been an integral part of everything that we've been doing here, and has been an extremely passionate and active supporter of pushing this promotion. So just thank you again, Anneke, for your time tonight, but also your time in all of the other Hangouts that we've done and all of the work that we've done over the past 5 or 6 months.
Oh, it's a big pleasure. Thanks for having me be involved.
Anytime. And as we said, we're hoping that this will continue into the future, and we'll let everyone know how we're progressing with that. But in terms of helping have that happen, any sort of feedback that everyone could provide in terms of how they've found the sessions and what they'd like to see in the future would be much appreciated. For everyone tonight, to Elizabeth, Tony and Brad again, Andrew again, and Adolfo, thank you very much for your time and participating. As I always say, we don't have these Hangouts unless you're involved. So thank you very much for your time, and we hope to chat with you all soon.
Thank you.
All right. Thanks, everyone.
Thank you.
See ya.
Thank
Thank
you.
you. Good night.
Bye.
Bye-bye.